Okay, I am going to go ahead and get started. Well, welcome everyone to today's intensive services grand rounds here in the Department of Psychiatry and Behavioral Sciences at the University of California, San Francisco. My name's Dominic Tarpey, and I have the pleasure of introducing our speaker, Dr. Sujatha Sankaran, whose grand rounds title today is Building Systems for Substance Use Treatment at UCSF Health. Dr. Sankaran is an associate clinical professor of medicine in the Division of Hospital Medicine here at UCSF. She has many important roles, and I'll just highlight a few, but for doing that, she completed her medical training at the University of Southern California Keck School of Medicine and her residency in internal medicine at Georgetown University. She is Director of Quality and Safety in the UCSF Department of Neurosurgery. She's the medical director of the Smoking Cessation and Substance Use Management, and then also chair of the UCSF Substance Use Disorder Committee. I've had the pleasure of working with Sujatha for the last several years and just appreciate her leadership and pulling together and leading a multidisciplinary team for these efforts in a complex system of care, and really in support of optimizing care for our patients. And so really appreciate having her here today to present. And so please, per usual, feel free to put Q&A in the chat and we'll get to them as we go along, or as much as possible towards the end. And other than that, I will pause and turn it over to Sujatha. Thank you.
Thank you so much, Dom, and I'm really excited to speak with you today about what we're doing at UCSF Health around substance use treatment. So I would welcome any questions, and we definitely will save some time at the end to talk about, a lot of what I'm going to be talking about is the system here at UCSF, and there are a lot of questions, and I'd love to hear insight and thoughts from you as well. So let me sort of start with what our objectives are today. So I think that, the goal really is to think about addiction, but really to think about addiction in the context of the system in which we all work. So really thinking and focusing on the inpatient side, really thinking about what are the different domains of inpatient substance use treatment here at UCSF? What are the components? What are we trying to do? What are the systems that we're putting together? And then ending by really thinking about your clinical care. So what are the systems as a clinician when you're trying to provide care for patients with substance use? What exists out there to help you provide care? Our agenda. So I'll start out by presenting the context, and I suspect that many of you already are familiar with this information around substance use and the overall context of substance use disorders. But then we'll talk a bit about the system here at UCSF Health. What are the domains and components? And then again, talk about our specific patients and what we can do. My only disclosure is this, that this is just challenging work, and I want to acknowledge that and start out by acknowledging that, and just that we're, we meaning the addiction efforts at UCSF Health and all of us who are working in this space are figuring it out as best as we can, and there's a lot of challenge, a lot of complexity, and we're trying our best, and just wanted to put that out there because I think this is an area that's really hard. And then also to think about, and acknowledge the experience and work of the people who use drugs in the system. And really thinking about, it's about the individual patient in front of us, but it's also about the systems and how do we dismantle some of those systems? How do we improve upon some of those systems to really create a way in which to provide more equitable care for everyone? I'm going to start with this case. This is a case that is a real case with a couple of details changed, but basically this is what happened. And it's a case that's very familiar if you work within the health system. And the focus really is in thinking about, what is it like as somebody who is not an addiction provider, who is trying to take care of a patient who's hospitalized, who has addiction. So I work in neurosurgery, as Dom mentioned in the beginning, and so this is a case of a 44-year-old woman who was transferred from an outside hospital to the neurosurgery service here at UCSF with severe low back pain, urinary incontinence, and fevers. A bit of her backstory. So she was healthy until she was hit by a car around 14 years prior, hadn't been taking any medications until that point, and then she very familiar story, started taking opioids because of pain related to shoulder surgery, and then was on these opioids for some time. At some point, the primary care doctor didn't want to give her any more refills, and so then she obtained heroin and really injected it in order to help relieve her pain, and is how she sort of described it. So when she came in, the neurosurgeons did what they do very well, and they, got imaging, and they found that she had this large lumbar epidural abscess. She got surgery and actually did very well for surgery. Had an uneventful course. Was given opioids for pain management, but then, following that, her opioids were weaned down pretty rapidly. So on post-op day 2, as they're weaning down her opioids, she began to experience shaking, anxiety, body pains, diarrhea. And at that point, she called her neurosurgical team and said, "I'm in withdrawal. I know what this feels like. I need something." And at this point, the neurosurgery resident, who was trained, obviously, in neurosurgery and was getting excellent training in terms of how to deal with neurosurgical patients, really didn't know what to do in this situation. So really what she was thinking was, should she give the patient opioids? And if she did give the patient opioids, was she running the risk of, quote unquote, feeding her addiction? Should she treat her addiction? How, what medications could she use? Was she allowed to even do this in the hospital? What would happen to the patient after she left the hospital? These were all the things that were swirling around for this resident. Meanwhile, at the bedside, the nurse was exhausted because this patient was, withdrawing, uncomfortable, and really just trying to manage the patient's intense needs. So to take a pause, we will come back to that case. And I think that sort of encapsulates a lot of the challenge in terms of inpatients of what we see. I'm going to back up for a second now and really think a bit about and talk about the opioid epidemic. And I know people probably know a lot about this and have read about this, but I want to just point out a couple of things here. So these are deaths per 100,000 on the y-axis here, and time. And it stops at 2019 in this. So we see increases after 2019 coinciding with COVID that I'll talk about later. But really what I want to bring up here is the fact that you see the slope of this trajectory here, and really this latest wave, what we're calling kind of the third wave, this purple line here of opioid overdoses really coincides with the fentanyl, with synthetic opioids, the fentanyl introduction into the drug supply. So that is really when you start to see this rise, this latest rise in opioid overdose deaths. And one thing that we know has happened and is happening is that fentanyl adulterates the opioid supply in a lot of places, and not just the opioid supply, but other substances as well. And so you sort of see that people sometimes often don't know what they're getting, and they don't realize that they're actually injecting fentanyl when they are. And then just to point out the fourth wave, what we see sort of happening now is the methamphetamine supply is largely adulterated with fentanyl, particularly in San Francisco, and it's sort of different based on the geographic region. And we see opioid overdose rates related to that as well. To narrow down a bit on UCSF Health now. So what do we see here at UCSF Health on the inpatient side? So these are just demographic characteristics of the patients we see. So we see that patients with substance use disorders broadly, not just opioid use disorder, but all substance use disorders, are more likely to have Medi-Cal for insurance. They're more likely to be experiencing homelessness, more likely to not be connected to primary care. And then if you look at some of these financial metrics that the institution talks a lot about, so higher lengths of stay, so their lengths of stay are about 2 times higher than other adult inpatients, higher readmission rates, there's a metric that's used called excess hospital days, so more excess hospital days. And what that really points to is they look at what is the diagnosis the patient has, what are they coming into the hospital for, how long are they staying in the hospital, and there's sort of an expected number of days. And really, people with substance use are staying longer in the hospital than what you would expect. And there are higher rates of largely higher rates of AMA just against medical advice or patient-directed discharges. So really much higher in this population. And it's dramatically 420% higher for patients with substance use disorders as compared to the overall population. And a quick note about that, we've looked at this population of patients who leave against medical advice quite extensively. And a lot of it appears to be untreated withdrawal. So we've sort of quantified that as well. And it really does seem that we're not treating their substance use. And so people often leave because of that. And then to make a note of COVID and sort of think about the context, and I know that this has been cited in the media, and so I'm sure people have heard of this comparison, but thinking about San Francisco in particular, looking at our rates of COVID deaths in an area where we weren't hit as hard by COVID as some other regions, and looking at our accidental drug overdose deaths, you can sort of see this difference that we have more than 3 times the number of people dying of drug overdoses than COVID. And I point that out mainly because there's so much that has been mobilized around COVID in the city as a whole, but also within UCSF Health. And there's a lot that was done in a very short time frame. And you could imagine that if we took similar steps within UCSF Health to do that, that we could make more of an impact on these numbers. I also want to point out the equity aspect of this. So we know that if you look at patients who are Latinx and Black, that they have a higher rate of overdose deaths. That's across the board. And particularly in patients who identify as Black, you can sort of see, we know that over time, and this is from 2014 to 2017, so a little bit older data, but we know that the rates of overdose have gone up, and these are deaths from overdose, have gone up for all substances, but particularly with synthetic opioids, so the fentanyl crisis. And I point that out also because I think the way that this epidemic has been portrayed is that it's a sort of an epidemic of rural regions of primarily white populations, and that's not the case. It's partly the case. It's part of the story, but the story is also that it's impacting all populations, and it's impacting Black populations at high rates as well. This is a little bit of a pivot, but I wanted to just bring up the fact that unhealthy alcohol use, so I'm talking a lot about opioid use, a lot of our substance use work in the hospital has been focused on opioid use, but if you just look at the numbers, unhealthy alcohol use and alcohol use disorder, it has more of an impact in terms of the numbers of patients who are impacted. So just to point out that when we talk about substance use, we're not just talking about opioid use disorder, we're also talking about unhealthy alcohols and alcohol use and alcohol use disorder. And some of the numbers, we know that there's 88,000 deaths per year from alcohol use. We know that these deaths continue to increase, and so they've more than doubled in the last 20 years. And really, in certain populations in particular, we know that the rates of alcohol use have increased, and the actual diagnosis of alcohol use disorder has increased. And the specific groups to think about are women, lower socioeconomic status individuals, and racial and ethnic minorities as well, in addition to older people. So I think that you certainly see that these rates are going up, and this is another substance use disorder that we're really focusing on in the hospital, really thinking primarily our efforts have been focused on opioid use disorder, alcohol use disorder, and now we're starting to think about stimulants as well. To give you a sense of the numbers, so every day we have improved in the past year our ability to screen patients for substance use and alcohol use, and we find that around 7 patients a day have illicit substance use who come either to the ED or the inpatient side, and about 5.7 for alcohol use. The alcohol use numbers we think are an underestimate because we're not getting as high rates of screening for that population. But this just gives you kind of a little bit of a snapshot in terms of the numbers. And if you look at the demographic, and this is for illicit substance use in particular, the average age is around 52, 2/3 male, mostly English speaking. But disproportionately Black, 23%, and disproportionately Latinx as well. Also, a couple of statistics that I think really stand out to me, 58% are Medi-Cal patients. And the one that really stands out is that 74% of these patients have screened positive for homelessness in the past 6 months. So just a lot of association with social instability. I don't know if this is something that you see a lot on the psychiatry side, but at UCSF Health and in the medical center, all over the place, we have these true north boards that hang up. And these are the things that the institution prioritizes: patient experience, quality and safety, our people, finances, strategic growth, academics through the learning health system piece. And I just want to point out that really everything we do with substance use really fits into every single one of these categories, that actually having a good system for treating patients with substance use it really is in every single pillar that we care about at UCSF Health. And it's really a matter of health equity. And this is something that we've been really advocating with leadership about, that actually having a robust substance use program is essential in terms of providing equitable care and really aligning with the priorities of the institution. So saying that as the background, I'd like to kind of talk a little bit about what's actually happening. So who is actually getting treatment? So these are patients who are admitted to UCSF Health. We've been looking at the numbers, and the numbers are pretty dismal, unfortunately. So these are the two medications that we've looked at here. So FDA approved pharmacotherapy for alcohol use disorder. In this instance, we were looking at naltrexone specifically because at that time we did not have acamprosate available. And this is looking at either methadone or buprenorphine for opioid use disorder. And we find that we are just not putting patients on pharmacotherapy. We're not putting patients on treatment for their alcohol use disorder. And for the opioid use disorder, we're not starting patients who are not already on it. And even the patients who are already on pharmacotherapy, either methadone or buprenorphine, we're often not continuing them on their treatment. We will talk a bit as we go forward on some of the reasons why we're not treating, patients as well as we could, and what we're trying to do to intervene. But I want to start by thinking a little bit about stigma and the role that stigma plays. And this quote from Nora Volkow, who's an expert in the field, is a lot more eloquent than something I could write, so I'm just quoting her up here. And what she says is that people who are addicted to drugs sometimes lie or steal and can behave aggressively, especially when experiencing withdrawal or intoxication-triggered paranoia. These behaviors are transgressions of social norms that make it hard even for their loved ones to show them compassion. So it's easy to see why strangers or healthcare workers may be rejecting or unsympathetic. And I think that we all feel this, and this is, it's again, I don't think we can underestimate the role that stigma plays. And when I think in my role about sort of the system and how do we improve the system, a lot of the barriers that we encounter, I think, are because of stigma. It's harder to get medications on formulary, for example, for addiction than it is to, let's say, get medicine for diabetes on formulary. And I think a large part of that really is stigma. And so I just sort of ask you to kind of keep that in mind as we think about why are we not treating these patients? Why are those numbers so low? So what are we doing here? Let's talk a little bit about that. So what we have built in the past couple of years on the inpatient side at UCSF Health is we've started out by really thinking about this as a kind of a quality and safety issue. So we've done the things that we do in quality improvement. We've built order sets. We have an opioid use disorder order set. We have an alcohol use disorder order set. We have a pager, and I'll talk more about each of these things in a little bit more depth, but we have a pager where we provide advice to clinicians. It's not a full consult service. It's clinician to clinician advice. That's really just been what are the structures in place on the inpatient side. We've also put together universal screening, so we screen everyone for substance use and alcohol use. And the emergency room side, where they see a lot of the impact of substance use disorders, they have a number of different initiatives they've worked on, including one that's been very successful around giving patients IM naltrexone for alcohol use disorder. They also have a substance use navigator. And they have some connections with some facilities such as Health Right 360 that have been useful in getting patients over there. On the education side, we have a boot camp, and there's a boot camp that's coming up that's going to be partially in person. So if people are interested, that's going to be in June. We have case conferences every other week, and we really have had a lot of engagement from social work and nursing in particular in those conferences. We have relationships with skilled nursing facilities, and we're continuing to try to build those relationships because a lot of times we can't discharge people because skilled nursing facilities don't feel comfortable taking patients with substance use. And on the outpatient side, we've been working with primarily Health Right 360 and Salvation Army Harbor Light, but also with our Department of General Internal Medicine opioid use disorder providers to really think about how do we improve capacity on the outpatient side. This is just a summary of what we have done. Some of this I've already said, I'm not going to repeat, but just to highlight a few things. In 2020, sort of 2020 to 21, we got these medications on formulary for alcohol use disorder. So now we have naltrexone and acamprosate both on formulary. We put together these institutional guidelines, and we're continuing to add to them. And we've included things like microdosing for opioid use disorder, some of the nuances of treatment. And so hopefully having those guidelines there allows us to have a resource we can send patients to, or not patients, providers to, when you're trying to treat these patients. Some of the other things that we're working on is really trying to expand our relationships with these skilled nursing facilities. And then, as I mentioned earlier, we started this screening all patients. And this is nursing-led screening. So the nurses are actually, during their admission assessments, are screening everybody for both unhealthy alcohol use and also substance use. We did a pretty extensive gap analysis, and we found that there were a lot of different areas that needed help, but one of the ones that stuck out the most was that social workers are overwhelmed. They often, part of what we initially had been saying is that management of substance use is really within the domain of the social worker, and then medical management would fall to the providers, but the social workers just don't have time for that, for extensive motivational interviewing and other interventions. So that's been a gap. Education, again, comes up repeatedly as a gap. And then just the fact that we're not treating people with pharmacotherapy is another major gap that keeps coming up. So one of the things that we've worked hard to do is to create this addiction advice service. So this is a pager service. It's only provider to provider, so it's not the power. You don't get the power that you do with an addiction consult service, where we're actually seeing people in person, but it allows you to have access to somebody who can help talk you through treatment of patients with any substance use disorder. There's an e-consult that can be put in, and then when we can, we actually do see patients in person, but often it's just provider to provider advice. We've been able to achieve quite a bit with this. Our volume it's about 200 patients a year now. So this is a little bit old, but about 200 patients a year, primarily opioid use disorder is what we're consulting on. This was always created as a stopgap measure, though, because what we believe we need is a full addiction consult service where we can actually see people, where we're funded to actually see patients in person. And but this is our starting point, and so we've done this really because there's a clinical need, and we want to make sure that we're in the interim, while we're trying to advocate for more services, we actually are doing something and providing advice to providers who need it. One other issue that has come up quite a bit on the inpatient side is this question about belonging searches. And so to give you a little bit of context, one issue that really has surfaced numerous times is when you have a patient who comes in and there is some suspicion that the nurse or the team has that the patient has substances on them and that they're trying to self-inject. Then a lot of times what happens is security is called and there is a belonging search. And this has led to a lot of really tense situations. And so we spent some time really thinking about what is happening with these belonging searches? What are people, why are patients getting belonging searches? And to be explicit about it, one of the things that really caused a lot of worry was, is this racially motivated? Who are we searching? Are we searching everybody? What is the threshold for actually activating a search? So we've done some work around thinking through this, and we found that this is a very small snippet that we looked at in 2021, but we found of 19 belonging searches, we found about 7 of them actually reached the patient. And really, those were the 19 for the year 2021. For that 7-month period, it was only 19 belonging searches where illicit substance use was suspected. And out of that, about 7 of the patients, really, there was an incident that actually reached the patient. And one conclusion after we did this analysis and we reviewed all these charts, one conclusion we came to was that part of what was happening in all of these cases was that there really was a patient who was concerned that they were going into withdrawal. And that was the major theme that emerged. And there was not trust between the team and nursing and the patient. And as a result of this, they felt that they needed to self-inject. And so or to attempt self-injection. So that was just a theme that came out in all of these cases. And again, I think gives sort of more ammunition for the idea that really we need to be treating withdrawal. We need to be treating patients' addiction a little bit better. As a result of all of these issues around room searches, one thing that has emerged at UCSF Health is the care support team. So what this is actually led by Samira Lopez, and I don't know if any of you know her. She was a psych nurse at Langley Porter. Fantastic. She's done a fantastic job of leading this team called the Care Support Team. And what this team does, it's really a team that's meant to think about why are these escalations happening where a patient becomes agitated or upset, or there's this concern that there's an illicit substance and a member of security is called. What's happening before things escalate? And what can we do to prevent these things from happening? And so what Samira and her team does is they basically see any of these patients where there is a hint of this, where there is a concern for escalation. So not just substance use related, but anybody where there's a concern for agitation or escalation of any kind. And then they just talk to the patient. They figure out what's going on. And in many cases, they call the providers and they say, the patient looks like he might be going into withdrawal. That's what's going on here. Can you please address that? And during their pilot, they actually found that about a third of their patients had coexisting substance use. And so that seems to have held even after the pilot. That's really seems to be the flavor of what they're seeing here. And so earlier addiction support is something that we're really trying to get for these patients. The other thing that's happening in general is we're really trying to make an effort to get social work involved as early as possible as we're planning for discharge for patients. And I think this is challenging because the social workers are so strapped and they're so busy, and especially it's been very difficult in the past year or so, but we're really trying to make sure that we make those linkages early. And in particular, for methadone, patients need to be linked to an opioid treatment program. So trying to kind of make sure that we're linking in social work has been really important. I'm going to talk about the case again now for a minute. So Miss S. So if you remember, she had come in, she had gotten this neurosurgery. She had felt really awful, was concerned that she was withdrawing. And the neurosurgery resident had been called, but there was a lot of uncertainty about what the best next step was. So now Miss S, she's languishing on the neurosurgery service with restlessness, pain, and diarrhea. The neurosurgery resident doesn't know how best to treat the patient. Her nurse suggests that methadone would help her symptoms. So the resident calls the inpatient pharmacy, but the pharmacist is unclear about whether it's legal to prescribe methadone in the hospital. So finally, there's a lot of back and forth, and finally, when she gets the green light to go ahead and give the methadone, she realizes that the patient's QTC on her EKG is prolonged at 525. So now she's concerned that she can't give methadone. In the meantime, while she's trying to figure out this system and what to do next, the patient is getting more agitated, so she pulls out her IV and stands up, and she decides to leave the hospital. So this is a real case, as I mentioned, and all of this happened actually. So there was this sort of confusion around, is it okay to give methadone to a patient in the hospital? And the QTC was prolonged, and the resident was trying to figure out what to do. So a lot of issues here to sort of think through. So what happened to her? So she ends up leaving against medical advice because she's in this opioid withdrawal and not been treated for her withdrawal. And just wanted to also point out the fact that everybody felt horrible about this. The doctors who were taking care of her, the nurses, the neurosurgeons were worried because she had this, just had this surgery. So nobody was feeling good about this. Everybody's feeling distressed. On her side, what she did was she went home and she used heroin to self-treat her withdrawal. After 2 days at home, her back pain actually became unbearable to the extent that she had she began to have high fevers, to the extent that she returned to an outside hospital emergency room and then was transferred back to UCSF. When she came back, her blood cultures were drawn and they showed Staph aureus bacteremia. And then in the next several weeks, she's found to have a recurrent abscess. Unclear if that would have happened anyway, but she did miss some antibiotics, so that could have been a contributing factor. She has to get neurosurgery again, and then she gets 6 weeks of IV antibiotic treatment. So there's a lot to sort of unpack around that, but I just wanted to take a moment and talk about one thing that I've mentioned all throughout is that the importance of education. And every time we've done needs assessments for substance use at UCSF Health, one of the main things that comes up repeatedly is the need for education. Everybody self kind of identifies that it's so important that they need better education. The nursing education is needed. So we did a survey of 121 nurses and asked them about a bunch of different domains around, what do you feel like you really need when you're treating patients with substance use? And this survey really showed that what nurses were self-reporting is that they felt that they really never received training. So 10% said they never really received training, but even the ones that did receive training felt like they just didn't, it wasn't adequate, and they just didn't feel like it was up to date enough, that they were getting continuing education around it. And the topics in particular they felt the most insecure about were, first of all, around OUD, really defining what is opioid use disorder, what is the treatment, is there treatment, how do I work within my organization to really provide care for patients with OUD. And then one important piece that came back repeatedly and was really reflected in the comments we got was around the biopsychosocial facets of addiction. Like, I just feel like I don't know I don't know how to interact with these patients and what I should be telling them and how to really treat them in a holistic way. That came across quite a bit. On the provider side, we did a hospitalist survey. So this was Division of Hospital Medicine, UCSF faculty. We surveyed around 40 hospitalists. And interestingly, the hospitalists said that they felt comfortable talking to their patients about alcohol use and opioid use and tobacco use. They felt okay with just asking the questions and screening patients. They felt okay with treating withdrawal. So they actually felt okay with that. They felt like they saw these patients a fair amount. But the area that they felt really deficient in was prescribing FDA-approved pharmacotherapy for these patients. And this is completely consistent with what we're seeing in our rates of treatment, where we're finding that we're not giving appropriate patients pharmacotherapy. And so it is consistent with what people are saying, that they just don't know how to give these medications. Another issue that has come up on the institutional level at UCSF is thinking about outpatient antibiotics. And so there has been a push to really think about, and this tracks with what the literature is showing, that really patients probably don't need to stay in the hospital to get all of their to get a full antibiotic course. And so we've started programs within UCSF to really think about, when can we get patients home for their antibiotics? And so this is something that is being done by the OPAT team, which is led by Rachel Bertritsky, who's an infectious disease physician. And her team focuses on figuring out, how do we get patients out of the hospital to give them IV antibiotics through their PICC line, and they actually have better outcomes when they leave the hospital sooner. But one thing that has happened is that they automatically are excluding patients with substance use because of this concern of people self-injecting into a line, sending somebody out with a PICC line, and concerns around what will happen and will they be able to, are they going to inject into their line? We have been advocating with the institution, though, to actually try to start enrolling these patients because it's being done in other places safely. And if you have an addiction program where you have an addiction consult service on the inpatient side and you have good outpatient addiction support, you can do this safely. So this is one thing that as we're advocating for more addiction support, we're really saying, this can actually not only improve care for these patients, but also reduce costs to the system. I'm going to spend a few minutes now just talking about what we can do as a provider, as an individual provider who might not have a specialty in addiction care. What can you do to take care of these patients who you see? And I think that a lot of people will already know a lot of this information, but so it might be a review for you. But just to begin with, one thing I see, again, consulting on the inpatient side with providers who are not addiction boarded, is that they don't recognize all the time the importance of just backing up and figuring out what the diagnosis is. Does this patient meet criteria for a substance use disorder? So I recommend, just whenever these issues come up and you have a patient where you suspect that there is addiction involved, to really think about, look at the DSM criteria and figure out, do they actually have a substance use disorder? And this comes up quite a bit around pain management, where you have patients who have been on a lot of opioids, maybe they have a chronic pain diagnosis, and there's this concern under the surface that there might be a substance use disorder involved. But really, nobody's gone through this criteria. Nobody's really made the diagnosis that this might be a substance use disorder. So really, as a first step, I would encourage people to find out, do they actually meet criteria for a substance use disorder, and is it mild, moderate, or severe? The other piece I wanted to review with you is thinking about, what are the medications that we use for opioid use disorder? What is their mechanism of action? So again, thinking about the inpatient side, the two medications that we use, that we have available at UCSF, are methadone and buprenorphine. And thinking again about how these medications work, they work on the opioid mu receptor. And as a reminder, methadone is a full agonist, whereas buprenorphine is a partial agonist, and naltrexone is an antagonist. And naltrexone we're not giving on the inpatient side, but basically, what you want to be mindful of, and the thing that comes up quite a bit, is because buprenorphine is a partial agonist, if you have opioids on board, if that patient is already taking opioids and you give them buprenorphine, you are at risk for putting them into precipitated withdrawal. Because what will happen, the buprenorphine, it's a partial agonist with very high affinity to the opioid mu receptor. And so if there is any opioid already on board, sitting there bound to the mu receptor, this high affinity buprenorphine will push that other opioid off the receptor and bind, but only give this partial effect, and the patient will go into withdrawal. So again, there's a lot of nuance to this, but just as a reminder, these are the medications we use, methadone or buprenorphine, and there is an induction protocol when you're giving the buprenorphine, so you just need to be cautious about giving it to somebody who's already on opioids. So as a reminder, one issue that came up in the case that I presented is this question about what's legal and what's not, and what can we do in the hospital. And this has come up on the inpatient side surprisingly more than you would expect, because it's very simple on the inpatient side. If somebody is admitted to the hospital for something else, so for an epidural abscess, for example, you can give them methadone or buprenorphine. There is no legal restriction to giving them methadone or buprenorphine. There's nothing you need to think about. When you are discharging them from the hospital, however, when they are on the outpatient side, then there are some laws regulating what you can do. So for methadone, they need to go to, if they have a diagnosis of opioid use disorder, they need to go to an opioid treatment program or a methadone clinic. So that you need to make sure that they go to a methadone clinic, and you're not allowed to give them any methadone. If they only had pain and no opioid use disorder, then you could give them a prescription. But for patients who have any diagnosis of opioid use disorder, you cannot give them a prescription. It is not legal. For buprenorphine, you can get an X waiver. So this is a special waiver on your DEA license. If you get this waiver, then you can prescribe buprenorphine for opioid use disorder. If you do not have this waiver, you cannot prescribe buprenorphine for opioid use disorder. So those are the main things around the legality. And this is just a summary of some of the things to think about. Again, for buprenorphine, the way the induction works is that patients need to go into withdrawal. And this is not an absolute rule, but the point is you need to take people off of their opioids before you start them on buprenorphine. We do have regimens that we are using now that are gradual up titration or microdosing protocols where you can do it concurrently, where you actually can start by giving patients very low doses of buprenorphine while they're still on their opioids. So there are regimens to do that. And on the inpatient side, we ask that people just page our service because we can kind of help. It can be a little bit tricky. We have included this in the institutional guidelines. And at UCSF Health, we have a buprenorphine patch on formulary that can be used for this. And so we can do a gradual up titration or microdosing regimen. And that can be good for patients because they don't need to go into withdrawal to be on the buprenorphine. So that's one thing that turns patients off often. And then methadone patients do not need to go into withdrawal for that. There are some things to think about, like the QTC prolongation. I grayed out the naltrexone because on the inpatient side, we do not have IM naltrexone, then we're not able to give it. And it's also incidentally not a great medication for inpatients because people have to be opioid abstinent for at least 7 days, and that's sometimes hard when somebody comes into the hospital for a short period of time. We have 2 order sets to help with treatment of substance use disorder. So we have an opioid use disorder order set, and it goes through the whole induction protocol. So I didn't reproduce the whole thing here, but if you click on buprenorphine, it'll give you the whole regimen. And it includes things like COW scores that the nurses will check. So that's something that is important to use. We also have an alcohol use disorder order set that has this clinical guidance in there to help people. And right now, acamprosate and naltrexone are on formulary. A summary of some things to think about. So to start out with, I would say substance use management is certainly within the scope of practice for someone who might not be addiction boarded. Like I mentioned earlier, for opioid use disorder, the first question to ask is, does the patient have opioid use disorder, which is very basic, but I feel like sometimes we miss doing that. And then again, the FDA-approved medications for OUD are methadone, buprenorphine, and naltrexone. And then all patients should be given naloxone or Narcan on discharge. There is in the system at UCSF, in Apex, there actually is an auto prescription for naloxone if somebody has high oral morphine equivalents. It will auto prescribe that on discharge. However, it does not do that for patients with substance use disorder. So anybody with an opioid use disorder, and the guidelines even say people with alcohol use disorder, and the reason is because there's a lot of people who have alcohol use disorder who also have opioid use disorder. All these patients should be given naloxone. As I mentioned earlier, AUD for alcohol use disorder, we have naltrexone and acamprosate on inpatient formulary. We also have this order set. Stimulant use disorder I haven't talked about, and on our addiction committee, we're just starting to think about approaches for stimulant use disorder at UCSF Health. There's no FDA-approved pharmacotherapy, but data does support mirtazapine, so something to think about. And then there are contingency management programs in the city, and so we're trying to improve access for our patients to those programs. So there'll be more coming on that in the future. And then finally, I want to spend just a few minutes now talking about addiction versus pain, because this comes up a lot on the inpatient side. So you have a patient who has addiction, you think, and you have pain, and is the reason that they're asking you for opioids because of their addiction or their pain? This comes up quite a bit. So I would start by just saying it's a false dichotomy. Patient has pain, but they might also have opioid use disorder. If somebody has one, they have a high likelihood of having the other. And in particular, 29 to 60%, so it's a little bit of a broad range here, of patients with OUD also say they have pain. And about less than a third of patients on long-term opioids develop an opioid use disorder. So you see that there is a good likelihood that they might have both. And I just want to also point out, I think that when we're thinking about treatment, just keeping in mind that it's all suffering. Addiction is suffering as well, and there's a lot that's underneath the surface that we don't touch particularly on the inpatient side, where everything is very rapid, where it's not this longitudinal relationship, but really a lot of acute things happening quickly. That it's important to just keep in mind how much goes into this and what's happening to patients and what the backstory is, because there's so much. I also just wanted to quickly put up this slide around getting an X waiver. I can also put the information in the chat. If you don't have an X waiver to prescribe buprenorphine, there's actually a new process that was introduced about a year ago. And this allows you to get an X waiver extraordinarily quickly, like 10 minutes you can get an X waiver. You don't have to go through the extensive training that they used to require for everybody. And for this training, you can really, once you go through this, you can prescribe for 30 or fewer patients at a time. So at a time, you can only have open prescriptions of buprenorphine on 30 or fewer patients. If you're not an addiction provider, that's probably sufficient for you. So I would really encourage people to get an X waiver. And finally, I just wanted to present an alternative ending for this patient, Miss S. So let's just say that instead of, when she's in horrible withdrawal, and the neurosurgery resident is called, instead of the neurosurgery resident being worried and not knowing what to do, let's say she's able to access addiction expertise from an addiction consult service. And with that guidance, let's say she's able to use the order set, the opioid use disorder order set, to medically manage the patient's withdrawal with medications. A healthcare navigator, let's say, is available to provide motivational interviewing. A social worker comes by and sets up a linkage to outpatient opioid use disorder management. The patient stays in the hospital because her withdrawal is treated. She finishes her antibiotics and she goes home without having to be readmitted and get surgery again. That is sort of the vision of hopefully what we'll be able to achieve for these patients eventually. These are just some resources. So I'd love to open it up for questions. This is our addiction committee, a screenshot of our addiction committee that you can see Dom is on as well. But I'd love any questions people have.
And thank you, Sujatha, for this excellent overview. Really wonderful kind of just to get the full picture. I do have one question, and that is, in addition to the things that you mentioned, like getting a full consult service or a more therapeutic resource, whether social work or whatever, for motivational interviewing, if you had a magic wand and in terms of a really great best practice, particularly for an academic medical center, what else might be put in place, for the, for all of this care?
Yeah, I mean, I guess I would say two things. I think one thing is, and I kind of have said it, but I really feel it strongly, is education for providers, for nursing, across the board, because I think that a lot of what we're talking about here, I think about it from my perspective as a hospitalist doing hospital medicine. We do a lot of complicated things and people are able to do that. And yet when they see patients with addiction, somehow it's hard to prescribe methadone or buprenorphine, even though you're prescribing all these other medications that are have a lot of really bad side effects as well and a lot of risks. So I feel like education, I think the thing that will move the needle is if people feel comfortable providing care to these patients. And so doing what we can to facilitate that. And some of that is culture change and some of that is education. I think that's one thing. I think the other thing we really need is, it would be great to have dedicated, whether it's social work or healthcare navigator or getting people with lived experience. Like, I think we need that kind of support as well on the inpatient side. And it's hard to make that argument to the institution because I think it's hard to show the financial return, just to be transparent about it. And I think that's what's been hard, but I think we need that resource as well. So education, and then I think having a little bit better of the psychosocial resources, really what I think we need. We have the substance use committee. And so if people are interested in this space, you can reach out to me. We would love to have representation from psychiatry in addition to Dom on the committee.
Yeah, and I will just second that. I have appreciated being on the committee. It's really, there's a number of these kind of committees at UCSF, and there's a lot of kind of cross-pollination. It's a big world we live in, and it can be very resource rich, actually, at least in terms of people. And so I think participating in a committee like this, but certainly for this topic, I think having more it would be lovely. So did you see, there's a question here, Sujatha, let's see. Oops, I'm curious what approaches you are envisioning regarding education.
Well, I have a few thoughts around that. I think the things that we've created so far around education, so it's sort of breaking it down into kind of provider education, nursing, and then kind of multidisciplinary. So for provider education, we have this boot camp that one of the addiction medicine fellows from a couple of years ago, who's now on faculty in DGIM. Her name is Jessie Ristow. She's running this addiction conference. It's fantastic. She really gets a lot of great speakers. That's a very provider focused, probably a boot camp that's really about medical management and treatment. That is one thing. Another group that we have that I would love to get participation from psychiatry or others on is we have a multidisciplinary case conference that there is every other week. And this is a group where we have a lot of participation from social work and nursing. And it's a case, it's basically just a case that we present and that we talk through and think about approaches on. I think one of the challenges here at UCSF, as everyone knows, is the sort of the nature of things is that each department is very separate and there's a lot of silos. And so we have, even when we take care of patients, if you have a patient who has pain and addiction, you have, the pain team giving recommendations, and then you have the hospitalist, and then you have the psychiatry team, and it feels like things don't mesh all the time. And so I think having a case conference where everybody is there, it's been really, really helpful. But I think we need participation probably from more providers. I think it's great that we have so many nurses and social workers that come, but we actually don't have that many physicians who come to that. And I think that would be great if we could also get a little bit more interaction that way. I think that kind of education, that clinical education, talking about cases we're seeing is really helpful.
All right, thank you. We have another question. Do you have suggestions for how we refer patients to contingency management programs given difficulties with access? Is there a list of these programs in San Francisco and surrounding areas?
That is an excellent question. So this is an area that we are actively working on right now because of what you say, that there's just poor access. A lot of the clinics, there are clinics in the city, a couple through ZSFG, but there is not a lot of, they're not taking patients at all of these clinics. We do have a list that I can disseminate, and on that list we tell you kind of who has availability and who doesn't. But we're trying to kind of strengthen those relationships to make sure that our patients have access. I think one thing I would recommend is when you're running into this, if you have a patient you want to refer, you can always page our advice pager. It's the 443-6272 number. I can put that in the chat as well. And that, we can always give you those resources.
Great, thanks. And Valerie put in a couple of resources. Thank you for that into the chat. And then Kevin, it looks like you have tracked the SUD program problem well. Is there similar tracking following patients over time transitions of care to see what interventions have succeeded?
Yeah, we haven't been as good at doing that. We did track a cohort of patients through a grant that we had, and the rates of treatment were low. I mean, I think part of the barrier is that we're finding we're putting so few people on medications in the hospital on pharmacotherapy that there's the N is very small because we're not putting that many people on treatment to begin with. But that is definitely a next step, and hopefully something that will come in the future.
In terms of the advice service, is it who's usually staffing? I mean, who's actually carrying the pager? Is it different kinds of physicians or others, or is it sometimes a team approach or like other disciplines?
Yeah, the way we're staffing it right now is we have two people who are addiction board. I cover it, and then Jesse, another one of the addiction providers. We have Matt Tierney, who's a nurse practitioner, who also covers it, and then we have different hospitalists who also carry some coverage. The thing that we're lacking at UCSF Health is we just don't have that many people who are addiction boarded, and so a lot of the questions tend to be kind of a little bit broader. So we don't always have the expertise to be able to, we don't have enough people to really be able to staff it. The other resource that exists out there is the substance use warm line. It's run out of ZSFG. They won't be able to give help around the specific nuances of UCSF Health, but they will be able to give great assistance in terms of clinical care. So I think that is another resource when we're not available that can be used.
Okay, well, are there any other questions or comments before we wind down? Okay, well, thank you, everybody. And thank you, Sujatha, especially. Oh, I know one other housekeeping. If sometimes we have people will ask for a copy of the slides, is that okay?
Yes, definitely.
Right. And normally a video of this will be posted to the UCSF Department of Psychiatry and Behavioral Sciences website in the next few days. If you want to watch it on replay or share it with a colleague or whatever, or your team. So with that, we'll go ahead and finish up, and thank you once again.
Thank you
Bye-bye.
all.